To introduce the next speaker, it's Dr. Vinod Nanjjaya, and he will be speaking on approach to a circulatory failure in ICU. Dr. Vinod is the head of cardiothoracic ICU. He is from Alfred Hospital, Melbourne, Australia. Uh, he is basically localite Kannadigan, born, brought up in Karnataka, but has been in Australia for the last 16 years. Over to you, Vinod.
Thanks, Farooq, for your kind introduction, and I would like to thank the organizers for this invitation. As the topic is broad and the time is too short, I want to, what I'm going to do is to give you an overall view of the acute circulatory states in ICU by going through a case and then talking about the pathophysiology and the phenotypes of circulatory shock and how we approach the management. So our patient is Rajappa. He's a 65-year-old male who's admitted to the coronary care unit, and you receive a MET call for hypotension. He was admitted to your hospital about 7 days ago with 2-day history of chest pain and was diagnosed with NSTEMI, and he had a staged catheterization procedure with stenting of his left circumflex initially, which was the culprit lesion, followed by the RCA and the LAD 4 days later. This was done 3 days ago, and as he had extensive stenting done, he was put on 3 agents, including aspirin, tecagrelor, and apixaban. He did not have any significant background history, and now the main thing that you find on examination is that he is drowsy but easily rousable. He has got cold, clammy peripheries, and he has got mottling along with that. His systolic is 80, his saturation trace is flat, and his saturation is unrecordable. And we noticed that he is in AF with a well-controlled rate with 60 to 80 per minute, and his lactate level is high, and the creatinine has doubled in the last 24 hours. So I think you get the gist of it. This patient is in shock state. So a patient in ICU who is in acute circulatory failure presents with shock state like this. In this case, we noticed that the creatinine has gone more than doubled over the last 24 hours. His lactate has gone up, and the patient is trying to compensate. In fact, he is overcompensated by his respiratory methods. And how do we reach this state of shock? So if you survey the patients in your ICU at any time point, 1/3 of the patients will be in circulatory failure or in shock. And we define shock as acute circulatory failure associated with inadequate utilization of oxygen by the tissues. And it usually manifests with hypotension. I'm telling usually, it's not always. Usually presents with hypotension, tachycardia, and evidence of tissue hypoperfusion and hyperlactatemia. And we know that about the oxygen delivery to the tissues is about 5 times the need of the tissues. And the oxygen delivery is determined by the cardiac output and the oxygen content. And the oxygen content is mainly determined by the oxygen bound to hemoglobin, which is the saturation of oxygen, and the hemoglobin in the blood. So when all these factors are low, the oxygen delivery to the tissues is low, and the tissues go into shock as a result of that. Conversely, if the oxygen demand of the tissues is high and the body is not able to meet that demand, then the body goes into shock, the cells go into shock. And when this happens, the oxygen requirement is determined by the oxygen delivery. And this is below a critical point, which is the critical DO2 level. And once the oxygen delivery goes below that point, the lactate levels, which is shown using the intermittent lines, starts going up. That is because of the cells switching from aerobic metabolism to anaerobic metabolism. I don't know what happened here, but the slide was What I was trying to show in this slide is the different phenotypes of shock that we see in ICU. So vasodilator shock or the distributive shock is the most common type, and sepsis is the predominant type of shock that we see in ICU. Nearly 2/3 of the patients will have distributive shock. So that's why sepsis management is very important for an intensivist. This is followed by the cardiogenic shock, which is in 1 in 5 patients, and hypovolemic shock, which is again in 1 in 5 patients, and obstructive shock is just 2% of ICU patients. And these are the various types of, or the various reasons for these 4 types of shock. But in ICU, we further consider them under 2 broad categories, which is essentially low cardiac output states because of either cardiogenic or obstructive shock, or hypovolemic blood loss or fluid loss, and then distributive related to the vasodilatory state. Let's go back to our patient. On going through the history, you find that he went into AF with fast ventricular rate 3 days ago, and he has been loaded with digoxin, started on amiodarone, as well as beta blockers. He had an unwitnessed fall 24 hours ago on the ward, and he has got a large bruise on his right lumbar area. And he also had episodes of diarrhea over the last 48 hours with blood-tinged stools. Remember, this guy is on apixaban along with aspirin and ticagrelor. And he also has fever and increased white cell count with a new cough and expectoration. And an echo which was done 4 days ago showed moderate LV systolic dysfunction involving the regional valves, and he did not have any pericardial effusion. So if we go back to our previous slide, this patient can have any of these 4 causes of shock, causes for his shock state. He has fever, white cell count rise, so he could have a severe sepsis, which is causing this state. He could be bleeding. He could have a large retroperitoneal hematoma because of which he has lost a lot of blood, or there could be internal bleeding because of apixaban, which could be causing shock state. He had presented with NSTEMI, so that could be the cause for his shock state, and he has received beta blockers on top of that on a moderate LV systolic dysfunction. So that might reduce his LV ejection fraction, and he might be in shock state as a result of that. He has AF with controlled ventricular rate. Remember, his heart rate was very high initially. Probably at that heart rate, his cardiac output was adequate. And as we have controlled his heart rate to 60 to 80, the cardiac output has fallen, oxygen delivery is reduced, and the patient is in shock state. Or it could be obstructive. He could have tamponade as a result of fall, or even pneumothorax as a result of multiple rib fracture, which he might have sustained during the fall. So in order to differentiate these types, in our practice, we usually use echocardiography. And I'm now going to go to these phenotypes here again. So this is hyperdynamic circulatory state. You can see the LV is filling, and it is coming nicely in. This is hyperdynamic state. And if the end diastolic volume was low with the papillary muscles touching each other, then that would be suggestive of hypovolemia in this state. This is suggestive of hyperdynamic circulatory state due to sepsis. And the way we manage this has already been discussed by multiple speakers already. So I would just briefly touch upon this. So we have to do the initial resuscitation, make a decision about whether to intubate this patient or not. Remember, he is very well compensating for his metabolic acidosis, which we may not be able to provide once we put this patient on ventilation. Then we have to think about fluids, antibiotics, appropriate vasoactive agents, and the MAP target and the lactate levels and SCVO2 in this patient. Imagine if this patient had this appearance on echocardiography. This is pericardial tamponade, and unless you drain the tamponade, you are not going to reverse the shock in this patient. So in this case, the treatment is drainage. The patient could also present, sorry, for some reason that slide is not playing, but what I intended to show was a severely dilated LV with severe hypokinesia, which is in this case was due to myocarditis. But in this patient that we are talking about, myocarditis is unlikely, but the patient may have significant LV dysfunction which is causing this. Alternatively, it could be valvular. This patient here, in this example here, has got infective endocarditis involving the mitral valve, and the patient has developed acute severe mitral regurgitation, which is the cause of shock. And if you don't correct this problem with surgery, or if the patient has got severe aortic stenosis, if you don't do valvuloplasty in the patient, then you're not going to be able to reverse the cardiogenic shock in this patient. So they are the main types of cardiogenic shock. And recently, the SKY has broadly classified them into two categories, which is heart failure related cardiogenic shock, which is the most common type of cardiogenic shock that we see in ICU, followed by the AMI cardiogenic shock, where literally the patient walks into the emergency department only to then go into shock and develop multi-organ failure. There are various classifications, including the Intermax profile for the chronic heart failure patient. The one I want to talk in this presentation is the SKY. SKY stands for the Society of Cardiovascular Angiography and Intervention Guidelines for Shock State, or the classification of shock state, which they divide from A to B, A to E. A is at risk, they are not yet in shock, but they are at risk of developing shock. B are the patients who haven't developed any hypoperfusion, but they have hypotension and tachycardia. C is the classic shock patients who require inotropic support. D are the deteriorating patients who are deteriorating in front of your eyes on inotropes, and you have to decide about mechanical cardiac support in these patients. And E is the extremes. Remember the cardiogenic shock that you get on table in the cath lab when you get an emergency call that the patient has arrested on the cath lab. They are the E stage, and these patients have got extremely high mortality. And unfortunately, the AMI-related cardiogenic shock, the mortality is very, very high, despite decades of research in this area. Whereas heart failure cardiogenic shock, the survival is slightly better. That's why the differentiation between acute myocardial infarction-associated cardiogenic shock and the heart failure-associated cardiogenic shock. Again, the treatment is optimized, the preload, afterload, contractility with inotropes, without increasing myocardial oxygen demand, and optimize the heart rate, which you all are aware of. The main thing that I want to draw your attention is towards considering temporary mechanical cardiac support when you notice that the therapy that you're providing is failing. And one of the things that is very, very important that I want to stress in this presentation is that early consideration of temporary mechanical cardiac support is very, very important. If the patients have gone into multi-organ failure, then you have missed the boat. So you need to start thinking about it before the patient has gone into florid multi-organ failure, when they are sliding on inotropes. And unfortunately, the time period available when they're in, with ARDS, you have time to think, whereas with cardiogenic shock, unfortunately, there is no time. There are various mechanical cardiac support devices that are available, including from IABP to VA ECMO. With the SHOCK 2 trial showing that there is no additional survival benefit, the utilization of IABP in AMI cardiogenic shock or cardiogenic shock per se has gone down significantly. The VA ECMO utilization has increased overall. There is Impella in the sideline, which is trying to, which some centers are using extensively, but the cost is a major issue for temporary mechanical cardiac support devices. And the other point to remember is once you have temporary mechanical cardiac support devices, you need to have a strategy. It is a bridge to recovery, bridge to decision about durable LVAD or BiVAD, or a bridge to nowhere. If you start a therapy without making that decision, then you will be on that bridge to nowhere pathway. The last phenotype that I want to talk about is the right ventricular failure, either related to pulmonary embolism or related to primary pulmonary hypertension or secondary pulmonary hypertension. In these patients, the therapy is slightly different compared to the other causes of cardiogenic shock. So you need to consider, we usually use vasopressin over noradrenaline in these patient groups, that is early utilization of vasopressors. And we usually insert pulmonary artery catheter because you can instantaneously monitor the pulmonary pressures, and then you can guide therapy using inhaled nitric or epoprostenol. Mechanical cardiac support is other option, especially in patients with pulmonary embolism, where the shock can be reversed if you institute them on their ECMO. VA ECMO is a very good therapy for right heart dysfunction. Temporary RVAD support can also be considered, but the main thing is you need to find the cause. If the patient has got chronic thromboembolic pulmonary disease, then you might need to consider pulmonary endarterectomy in those patients for weaning them from ECMO. And if the patient has got primary arterial hypertension, which is severe, you will not be able to wean the patient. It is extremely difficult to wean these patients. So before putting those patients on ECMO, you need to have a strategy for lung transplantation in these patients. Now let's go back to this patient. What we actually found in our patient Rajappa was a severe LV RV dysfunction, which was probably related to the beta blocker, along with the large pericardial effusion, which was causing his poor cardiac output state. And this patient also had sepsis. And this is a typical case that we see. It is never a one diagnosis. It's usually multiple, and you have to think and treat them accordingly. So in summary, circulatory failure manifests as shock, and 1/3 of the patients have that in your ICUs. Echocardiography plays a very important role. And based on what you find in echocardiography, the management needs to be tailored, and consider mechanical cardiac support early in patients before the train has left the station. Thank you very much.